Okay, so our next speaker is Gilli Moorhawk. She's been involved in the complementary health field for over 30 years. She trained with the Institute in 2013 and 2020. Gilli has been interested in birth trauma since the age of 5, when her mother told her she had been a premature born baby, so she was 7 weeks early. She always asks clients about the birth experiences and finds many sources of insight and roots of current life problems from this investigation. She runs workshops on embodied creativity and wellness, and also sees clients one-on-one. Gilli is the author of Meditation and Positive Thoughts for Pregnancy and Birth, the first book on meditation for pregnancy, and Miracle Baby Stories about women's experience of infertility. She is an editor on the Cantin Ketogenic Diet for Cancer, and her next book, Embodied Sexuality, is due out in the 3rd quarter of this year. So, Gilli, over to you.
Thank you, Shane. So, as Shane said in the introduction, I've been interested in birth trauma since the age of about 5. My mother told me that she'd had 2 babies born before me, a brother and a sister, who both died at birth. And then I was born prematurely. So, you know, I always wondered why I ended up writing books about pregnancy. And I think basically that's why this is all about my own trauma. And I've just always been fascinated about how birth trauma drives our trauma responses through life and affects our mental and physical well-being. So, although the peak states model covers trauma going back through to conception and events that happen in the course of pregnancy, I'm going to look mainly at how historical birth practices lead to birth trauma. And I was really quite shocked about this. I didn't realize just how neglectful and abusive our normal birth practices were. And I also want to talk about how we can change things for people so that pregnancy and birth are much more trauma-free events for our children and their children going forward. So when we talk about birth trauma, it's often these kind of things that we talk about: a long labor, the baby born blue has to be resuscitated, the cord around the neck, the baby gets stuck and it's a forceps birth or WOM2s. The mother has preeclampsia, which leads to problems for the baby and often emergency cesareans. Placental abruption, when the placenta detaches from the uterus before the baby is born, causing a life-threatening situation. And any kind of premature birth, which is a baby born before 37 weeks or weighing less than 5 pounds. And of course, some premature babies are extraordinarily small when they're born. I think the youngest surviving preemie was 21 weeks. So when you consider a pregnancy is 40 weeks, 21 weeks is barely half the length of a normal pregnancy. And due to all the high-tech interventions, that baby survived. So when we talk about birth trauma and talk about trauma, one of the common things that people talk about is the Adverse Childhood Experience Index. This is an online questionnaire or a questionnaire that therapists can use. And it talks about neglect and abuse and all kinds of negative childhood experiences. So I was really surprised when I read a book by one of the experts on ACEs, Dr. Nadine Burke-Harris, and she didn't mention birth trauma at all, not a single sentence. And I've spoken to some people who don't score very highly at all on the ACEs score. They may have 1 or 2 things, yet they still demonstrate very severe levels of trauma and mental health problems from trauma because they had birth trauma. They had adverse birth experience, ABs, rather than the ACEs. So some children manage to endure terrible privations and abuse in childhood and seem to come out the other end without many negative effects, and it's really surprising. So these children were often called resilient children, and what seemed to happen was that they had strong supportive relationships from their extended family that really allowed them to have a certain sense of themselves, a robust sense of themselves that got them through all these difficulties. But the adverse birth experiences, I believe it primes the nervous system and makes it much more sensitive to later trauma in life. And definitely with PTSD, two people can experience the same trauma and one person will walk away and it won't follow them full, and another person will develop PTSD. And it seems to be that very early trauma is the predictor for which person is going to be affected most severely. So Grant and I spoke last year about how cutting the cord too early is one of the key things that causes the loss of peak states in newborns. We should be born with various peak states, and Grant believes that it's this single trauma that causes a lot of the damage for newborns. It's been known for a long time that cutting the cord early is not a good thing. Since 1773, a doctor called Charles White said that it wasn't a good idea, that you should wait until the cord had stopped pulsing before it was cut. Erasmus Darwin in 1801 said the same thing. Professor Pierre Boudin, who's a French professor of neonatal health, he measured the blood denied to a newborn by clamping the cord too early, and it's about 1/4 of a can of Coke. Well, which you compare that to the size of a baby, it's not an insignificant amount of blood to be missing. And the impact on the baby is jaundice, respiratory problems. It's just, never mind the peak states thing that we're really interested in. Physically and physiologically, this has a big impact on babies, especially premature babies. In 1938, they discovered that the placental blood was rich in stem cells. And so this placental blood now became a financially viable product, which was another reason for it to be clamped quickly and taken away. So the baby and the mother didn't benefit from this financial windfall, but of course hospitals had an incentive to keep the process going because it was quite a big money spinner. I spoke to a junior doctor who was telling me about a baby that he delivered unexpectedly in A&E. And I asked him how long he waited before clamping the cord or before cutting the cord. And he said 2 hours. And I was gobsmacked that finally, 30 years after I read that cutting the cord early was a bad thing, finally it's kind of filtered down to the front end of medical school. So he's a junior doctor, so he's just come out of the medical system. So it's clearly it's now part of the medical practice, at least in some hospitals. But maternity is reluctant to change maternity care. So it's really important for us to talk to our friends and relatives and explain to them how important this is, so that when they make a birth plan, they can be quite insistent that this happens in their birth process. So psychologist John Bowlby in the 60s and 70s suggested that babies are programmed to connect to their caregivers, and he recommended that children should receive continuous care from their primary caregiver for at least the first 24 months of life. So this is all about the key trauma is not the birth trauma. The key trauma is the separation from mother, and Celine touched upon this in her presentation yesterday. What we find is that people who have a break in the bond with their mother, it's often a relationship that is never repaired, and it continues to be a difficult relationship for the rest of their lives. And I can't help wondering if the current obsession with fame and attention on social media and clicks is due to the lack of mother's attention in early childhood, due to mothers routinely being separated from their children because they go back to work quite early. So birth practices, when I started looking into this, I was horrified to realize that babies have routinely been separated from their mothers at birth for the whole of the 20th century. Because it was routine for mothers to have a couple of weeks after the birth, either in a nursing hospital or in the hospital, the way that the maternity hospitals worked was that babies were kept in a nursery and were brought to the mother only for feeding. So the mother would see the baby maybe 3 or 4 times in a day. Every 3 or 4 hours, the baby would be brought for feeding. And the baby would be separated from the mother for these key early period of time. And people thought that the babies just slept. And they thought that the babies were fine. They were all wrapped up in their little cots and they were asleep. And it was only when they started being able to do brain scans that they found that the babies were actually in a state of freeze. They had literally switched off because of the shock and trauma of being separated from their mother and not being able to kind of fulfill their prime early activities because they weren't getting the connection with their mother's body. But you know, the things that they did do were amazing. You know, premature babies in the late 19th century would die routinely, and it was only through the intervention or the invention of incubators in France by 3 doctors, Dr. Lyon, Professor Boudin, who we mentioned earlier, and Stéphane Tarnier. But the medical profession wasn't really that interested because it's just a baby and it's just going to die and it takes too much care looking after them. So why would we invest in these machines? So Boudin displayed premature babies in incubators at the Berlin Trade Fair in 1896. So this is what they looked like. And people were fascinated by this. It was part of the trade fairs that were very common in the early part of the 20th century, which would launch all the new machines and the new discoveries, and people would come from miles to see these tiny little babies in the machines that were keeping them alive. And Martin Courin seemed to save about 6,500 babies' lives with his incubators. And although Professor Boudin recommended that mothers were there to take care of the babies, that wasn't particularly convenient for Mr. Courin. And he took the idea to America, but he kept the mothers away from the babies and only had his nurses doing the childcare. And around about 1940, the hospitals finally decided that having incubators was a good idea. And they, instead of adopting Professor Boudin's recommendations, which was having the mother, the key primary caretaker for the babies, they took on the whole recommendation of just giving the babies to nurses, that nurses were a better source of care for the babies and to keep the mothers away as much as possible. What Martin Courin discovered was that when the babies grew old enough to leave the incubators, often the mothers didn't want them back. The mother-child bond goes both ways. And sometimes he literally had to force the mothers to take the babies once they were over 5 pounds and could survive well enough. And tragically, many of these babies were returned to the hospitals and to the A&E with broken bones and battered bodies because the bonding process had gone astray with the mothers because of these long separations. So, you know, all the way through the 20th century, babies were routinely separated from their mothers for the first couple of weeks of birth. As mothers started going back to work in the 60s and the 70s and the 80s, again, this separation was occurring between mother and baby. And there's three different levels of childcare. The best one is being at home with the mother. The second best is being in the care of somebody else in your own home. And the least beneficial is childcare nurseries, which of course is where so many children are brought up these days. So this is what a childcare nursery looked like. The babies were in their little cots and people could look through the window at them. One thing I found that's really quite interesting with people who were premature babies is they often have a feeling that people are looking at them. And people keep telling them, don't be stupid, of course people aren't looking at you, but they still have this sense. And I think it's a trauma from being in these nurseries where you don't have any physical touch and all you've got is people staring through the windows at you. So apparently hospital nurseries were still in place in some hospitals in 2002. People were trying to stop them, but what they found was that people really liked looking at the babies. People would come from other parts of the hospital and would feel inspired by the babies, but it just meant that they were still being separated from their mothers as recently as just into the 21st century, which is kind of tragic, really. So on the other hand, I just want to touch briefly into reproductive medicine, which is another source of trauma. A little bit earlier on in the gestation for us, people are probably generally not very aware of what goes on with reproductive medicine. One of the earliest things is freezing sperm. Sperm can be thawed and refrozen 3 times without any obvious reduction in fertility. And this has been going on since 1953. In the 70s, drugs like fertility drugs, which boosted the production of eggs in the women, fertility drugs like Clomid were introduced. And this is one of the least invasive forms of fertility treatment because the eggs are still being produced inside the body. The sperm is still being put in the natural way. And it's just that when you've got more eggs, you've got more chance of one of them getting fertilized. In 1978, we had the first test tube baby. This was one of the more invasive forms. When fertility drugs were used to create more eggs, the eggs were harvested and mixed with sperm in a test tube. And then the embryos were reinserted back into the mother's uterus. And round about this time, they started to freeze embryos. If people had 6 or 8 or 10 embryos produced in the processes, they could freeze them for later on. And the oldest frozen embryo, which developed into a live full-term baby, was 20 years after creation, which, you know, we have no idea what the long-term impact of these things is. One of the things that I have the most problem with is a process called ICSI. So it's normally here you can see the sperm goes in through the protective shell of the egg. And with ICSI, a sperm is taken into a syringe and the syringe pierces the egg and inserts a sperm that the doctor has chosen into the egg. Recent research in Stockholm in 2020 in association with one of the British reproductive clinics found that the egg, as we know already, the egg chooses the sperm. So in the same way that the woman tends to choose the father of her children, the egg also chooses the sperm that it wants to have as its fertilizer. So when you're doing ICSI, it's a bit like rape, really, because you're putting a sperm of your choice into the egg and not the egg's choice. There seems to be more risks of autism and intellectual impairment using ICSI compared to any of the other reproductive techniques. Pre-implantation genetic diagnosis, this is when they allow the embryos to grow, the blastocysts to grow to 50 to 200 cells now. It used to be done earlier. And they will suck one of the cells off and analyze it to see if there's any genetic damage. Usually Down syndrome is one of the things that they can test for. So again, the blastocyst is being injured in some way, and we don't really know what kind of impact that's going to have on the fetuses. Though the one thing they do know, there's a higher risk of genetic malformations in IVF and ICSI babies, and a 6 times higher risk of genitourinary defects. So not surprisingly, there is some significant impact with these techniques. In the mid-1960s, they developed a neonatal intensive care unit, particularly for dealing with very early, very preterm babies. And these tiny little babies are wired up to all kinds of machines. They have between 6 and 12 painful procedures every day, and there's no anesthetic or no pain relief used on these tiny babies. Often they are held down physically by several nursing staff to have these tubes and pipes and needles put into them. Until very recently, the ICU was constant 24-hour daylight. So the circadian rhythms of the babies were also affected badly. And the baby would be isolated from the mother for weeks until considered healthy enough to be sent home. One thing that I found, which just shows how barbaric these things are, and how you just wonder how people can be so thoughtless. But apparently until the mid-1980s, doctors were still performing open heart surgery on newborn babies without any anesthetic. I'm just gobsmacked. I can't think how they can do this and what kind of long-term impact this is going to have on a baby. So things are improving. Kangaroo care was developed in Bogota in South America, where, as has been normal for thousands, tens and hundreds of thousands of years, the mother carries the baby next to her skin from birth. But because of the medicalization of maternity care, the belief was the baby was safer in an incubator than it was in its mother's arms. The mother was considered to be dirty, a risk of infection, couldn't look after the baby as well as the nurses could. And so there was this routine separation. And, of course, we know that this is massively traumatizing for a young baby. So kangaroo care and skin-to-skin care is becoming more common. There was a story I read about a baby in intensive care that was dying, and the doctors removed all the tubes and machines from the baby and gave it to the mother to look after it and hold the baby until she died. Except the baby didn't die. Being put into the arms of his mother was what it needed to recover and for its energy to be used for supporting its own growth, rather than just this survival panic state that it was in when it was in the incubator on its own. So the research supporting skin-to-skin care is more than 30 years old, but it's only just coming into maternity care now. There was a paper in 2014 about how to reduce trauma in our babies, and the Neuroscience of Birth by Niels Bergman's really interesting paper says the human newborn is perfectly wired to develop after birth as long as it has the physical cues from its mother. And taking it away from the support of the mother means that so much of its energy has to be plugged into survival rather than development. And babies who were left alone in a cot rather than being skin to skin had 3 times higher autonomic nervous system activation compared to babies with skin care, and higher levels of cortisol, which activating negative set points that persist through life and lead to long-term illnesses. So what can we do to make things better for the next generation of babies? Education. The information that I've given you here is often not available in mainstream. So we have to tell our sisters, our daughters, our cousins, our nieces, our female work colleagues, and their partners. In these days, people have lost sight of the importance of health and well-being of the parents before they conceive. In the old days, the people got engaged before they got married, and the engagement lasted for about 6 months. And the son would be taken back to his village, and the girl would be taken back to their village, and they would be fed on the best diet, the best food that was available in the village, so that the children would be produced from healthy eggs and healthy sperms. So this is nutrient-dense food like liver and offal, fish eggs, cod liver, berries, chicken eggs. You know, you can't make a healthy baby from pizza and pasta. Dealing with your own trauma, particularly your trauma around birth and any ancestral trauma you may have around birth, if somebody died giving birth, if other babies died before you were conceived. These are the things that can be dealt with so that you're going into carrying your baby with much less trauma. And some peak states are inherited, we know this. So if you can get some peak states for yourself, that's going to be a really great start for your baby. One of the reasons lots of women end up having medical intervention is because they're simply not fit enough to deal with the rigors of birth. Pregnancy isn't an illness. Pregnant women are not fragile and delicate, and health is key for mother and baby and for a successful and easy birth. Insist on delaying the clamping and cutting of the cord. This is, we know, is one of the primary things that really matters. And in Australia, mothers go an extra mile and don't cut the cord for hours or even days after birth. And this is called lotus birth. They wrap the placenta in a cloth and it's carried around with the baby until it detaches naturally. The next one is a very difficult issue for people in these days, and that's for the mother and baby to be together for the first 3 to 6 months, ideally skin to skin all the time. And of course, with mothers going back to work within 3 months or 6 months, and with the way that our society runs these days, this kind of care, it just seems impossible for lots of women to do. However, this is the way to give any baby the best start in life. And childcare with mother or another family member as the primary caregiver until the age of 5. That's it for me. I hope you find the talk interesting. If you have any questions, let me know.
Okay, thank you, Gilli. Really liked the presentation. I can say that I've actually followed some of your recommendations.
Excellent.
So my wife and I, our son was born about 7 months ago. Naturally, being in the Institute, we've been doing lots of healing around having peak states so that, like you said, they're inherited. So our son would have them as well. Certainly been healed trauma, our own birth trauma as well, to try and reduce that impact on him. But your point around the lotus birth in Australia, that Australia's not the only country that does it, but it does seem to be more common in Australia than anywhere else, even though it wasn't invented in Australia. But our son is a lotus birth child as well. So we didn't cut the cord at all. You know, we looked after the placenta for a few days until it just naturally fell off. So yes, we're hoping that sets him up for a much less trauma-free life.
But how is he as a baby now?
Most of the time, very happy, very, very curious, very active. So yes, I think that at the moment the signs look very good.
Excellent. I'm really pleased to hear that, Shane. That's really good.
Thank you. Let me see. Got a question around, have you heard of the Dunstan baby language and elimination communication?
No, that's a new one on me.
Yeah, so the Dunstan baby language, she noticed that there were particular sounds that the baby makes, particularly in the first, I think it's first 6 months. Because one of the things when the baby cries is trying to figure out, you know, what does the cry mean, right? And so as parents, we're quite often trying to figure out, do we need to feed them? Do we need to put them to sleep? Do they need to change? And she identified that there were particular sounds that consistently meant the same thing. There was a particular noise that meant that they were hungry, a particular noise that meant that they were tired. So that's kind of interesting way to support the bonding between mother and child, being able to more effectively communicate with the child as well. And elimination communication is around helping them be toilet trained at months as opposed to maybe at 2 or 3 years, again, by being able to pick up the signs and follow some. So yeah, there's lots of success stories around having them being, I guess, potty trained at very young ages. Again, you know, they're sensitive to these things. They know that you know, they don't want to be soiling themselves, and so teaching them how to deal with that at an earlier age.
I have a story about that actually. In one of the charities that did medical care for babies in Africa, they noticed that the women would be queuing up with the babies for hours in the sun, but nobody ever soiled themselves. There was never any, you know, mess, and even though the babies were there, that the women would just trot off to the bush quietly. And they said to the women, "How do you know when your baby needs to go to the toilet?" And the women just looked at them like, you know, like, "You're crazy." "Well, of course we know, you know, because I'm in tune with my baby. So when my baby needs to go, I know." And, you know, they obviously thought that the medical people were a bit dumb.
Okay, well, thank you so much, and look forward to you joining us at the panel at the end of the presentations today.
Thank you, Shane.